Welcome to the Surviving to Thriving podcast with Jim Squire. I'm a licensed psychotherapist here in Toronto, Canada, and the title of this episode is ADHD, Trauma, or Both. Picture this. You're in a meeting, someone's talking, you're nodding, you look present, and 40 seconds ago you were somewhere else entirely. Not daydreaming exactly, just gone. Then you catch yourself, spend the next 2 minutes trying to reconstruct what you missed, while also monitoring your face to make sure nobody noticed. Is that familiar? You probably already asked yourself the question a lot of my clients ask in the first session, or at some point, is this ADHD? And here's what I want to say before we go any further. That might be exactly the right question. Or it might be the wrong question asked in the right direction. Because in a trauma-informed practice, the honest answer is often more complicated than a checklist. It could be ADHD. It could be an old nervous system pattern, something that happened long before adulthood. And this is a lot more common than you think. It could be both, tangled together in a way that a 15-minute online quiz was never built to untangle. But that's what this episode is actually about. Not a tidy yes or no, but the real research and what it's actually showing, including where the researchers disagree with each other, so you can walk away with perhaps a better picture, maybe not the one that fits an Instagram carousel so well. What ADHD actually is clinically? Let's start with the basics, because most of what circulates publicly about ADHD is either oversimplified or out of date. The DSM-5, which is sort of the manual that mental health professionals, psychiatrists, consult for a diagnosis. And in the DSM-5, which is the most current version, it recognizes 3 presentations of ADHD in adults: predominantly inattentive, predominantly hyperactive, impulsive, and what they call combined. For an adult diagnosis, you need at least 5 symptoms in one of these domains, symptoms that trace back before age 12, and this part gets skipped a lot. They need to show up across more than one setting, not just at work, not just at home, both. Here's something that surprises people. The older, more sophisticated modeling of ADHD symptoms actually suggests something more nuanced than these 3 tidy boxes. Some of the newer factor analysis research proposes what's called a bifactor model. One general ADHD factor plus separate specific factors for inattention, hyperactivity, and impulsivity. In plain language, ADHD isn't just one thing that shows up in 3 flavors. It's more like a cluster of related but partially independent traits, and how they combine is different in every person sitting in front of me. And critically, in adults, hyperactivity often doesn't look hyperactive anymore. It's not bouncing off the walls. It's internal restlessness, a mind that won't idle, like bouncing under the desk, a driven, can't relax even on vacation quality. Clinically, we describe this as developmental. The overt physical hyperactivity of childhood turns inward with age, while inattention tends to persist and in many adults becomes the more impairing feature. Multiple recent reviews confirm inattentive symptoms are actually the strongest predictor of real-world impairment in adults, more than hyperactivity, more than impulsivity. One more thing worth naming, ADHD is highly variable. 2 people in the same diagnosis can look almost nothing alike, and it rarely travels alone. Somewhere between 60 and 80% of adults with ADHD have at least one other co-occurring condition: anxiety, a mood disorder, learning disability, and sometimes autism, which is exactly why a 15-minute checklist online is not a diagnosis. It's just a starting question. Having worked in hospitals for years, I'm very used to the medical model which focuses on diagnosis. Having worked in private practice for over 10 years, I no longer worry about, nor do I have to worry about, a diagnosis. The structure within, say, a hospital would be that the person would come in, they would go to generally a psychiatrist for a diagnosis, then a treatment model would be developed and executed based on that diagnosis. The problem I found working in that system was that a lot of people that had trauma, a lot of people that had other challenges, even substance abuse, were misdiagnosed or labeled in some way that didn't accurately describe them. One of the things I typically find with people is that because a diagnosis may occur over 1 or 2 sessions with someone, you're kind of looking at someone at a point in time. And for a lot of my clients who used to come to the hospital, they would often talk about how they were high or hungover or under the influence of something, having just gone through a breakup or something to that effect, and they didn't share that. So the diagnosis was looking at things that and attributing certain factors to it that may not be real. The problem with that situation is people are generally going to be cautious about what they share. They may want to be liked. They may not want to share certain very negative aspects of their history, such as drug use, etc. So it's really hard to get sometimes a proper diagnosis. Unfortunately, a lot of the people that do a diagnosis don't have a relationship with the person they're diagnosing. They're just meeting them a few times. And I'm not saying that's not helpful, but it still is something that we want to, especially as practitioners, be careful of. If someone is coming to you and identifying, saying, I have this diagnosis, we want to see how they feel that fits. And we want to be looking at other areas too. We don't want to just stay in that one lane unless that, of course, is what the client wants, because we may be kind of limiting how well we can help someone. Here's the part that most ADHD content won't touch, and I think it's the most important segment of this episode. There's a real ongoing disagreement among serious researchers, not just online commentators, about what's happening with the sharp rise in adult ADHD diagnosis over the past decade. One camp argues this is an overdiagnosis. Their case says that diagnostic criteria has broadened over certain editions of the DSM. Awareness has exploded through social media, and symptom criteria themselves involved inherently subjective judgment calls, a clinician deciding whether something happens often or whether it's significantly impairing. That's not hard science, it's clinical judgment applied to a checklist, and judgment varies between practitioners. Critics in this camp worry we're medicalizing normal variation in temperament and turning garden variety modern distraction into a diagnosis. The opposing camp, and this includes a lot of the neurodiversity movement, argues that what we're actually seeing is an underdiagnosis finally correcting itself. Their point, diagnostic criteria were built in hyperactive little boys, which means generations of inattentive adults, and especially women, were missed entirely. For a lot of late diagnosed adults, getting the diagnosis isn't inflation, it's the first time their life has made sense, and research does back part of this. The shift from the DSM-4 to 5 criteria alone accounts for a documented jump in prevalence. One large field trial found roughly a 27% increase in expected diagnoses purely from this criteria change. Before you even factor in awareness or access, here's how I land, where most careful clinicians land. Both things can be true at once. Some people have been appropriately identified after decades of being missed, and the ease of self-diagnosis culture online means some people are pattern matching normal executive fatigue from burnout, poor sleep, from overloaded life onto ADHD language because it's the most available explanatory framework right now. The clinical task isn't picking a side in that debate. It's doing careful enough assessment that you can tell for this specific person which one it is And that is important. Increasingly, research are describing ADHD less as a binary, you either have it or you don't, more as an extreme end of a trait continuum, similar to how we think about blood pressure or body weight. That reframing changes how a rigid yes or no diagnostic line should be drawn. Where I find myself struggling, in fact, I've had a lot of clients referred to me at what was initially said to be ADHD. And the question then becomes, is this ADHD or is this trauma? And so if you're not a trauma therapist or you don't work a lot with trauma, you might just assume it's ADHD. The problem would be similar to anxiety. If you focus on, for example, anxiety and the issue is trauma, the person is not going to progress well. And the same I found with ADHD. If you target it as ADHD, and there's really, there's trauma needs to be processed, the person is not going to progress or do well. So this is a segment I want you most to sit with, because in trauma-informed practice, this distinction is an academic. It changes the entire treatment plan. Chronic hyperarousal from trauma and inattentive presentation of ADHD can look nearly identical from the outside. This is the one I see the most. Difficulty concentrating, disorganization, forgetfulness, emotional reactivity that seems disproportionate to the trigger, a nervous system that's scanning for threat instead of following the conversation in front of it. There's a growing body of research specifically on this overlap, which looks like classic ADHD inattention. The glazed over, checked out quality can actually be disassociative, a subconscious avoidance response, something that feels unsafe even when the person can't name what that something is. For people that are not aware, what we would normally see with children that have experienced trauma is they would disassociate. They would shift to a kind of half-present state to cope with the overwhelming and scary nature of where they are, because they can't physically leave. Generally, when they're little, this is a way that the system is coping with the overwhelming experience of the environment. So back to ADHD, what looks like ADHD impulsivity can be trauma-driven startle or defense response. And what looks like emotional dysregulation from ADHD can be nervous system stuck in a chronically activated state from unresolved trauma. There's even more research on this now. One recent study directly comparing dissociation severity across people with trauma histories versus ADHD symptoms found something interesting. Dissociative symptoms are actually most associated with ADHD symptom severity itself, more than the trauma exposure, which tells us the relationship between inattention, disassociation, and trauma is more tangled than trauma mimics ADHD. Sometimes the neurodevelopmental piece is driving dissociative type experiences on its own. Why this matters: if someone gets an ADHD diagnosis and a stimulant prescription, but the underlying driver is actually unresolved trauma, medication may take the edge off some of the symptoms without touching the root cause, and in some cases it can even sharpen anxiety symptoms that are being partially masked by the inattention. Conversely, if someone goes through trauma-focused work like EMDR, with anyone screening for a genuine independent neurodevelopment ADHD presentation, they may keep hitting a wall with executive function symptoms that trauma processing alone won't resolve. And that's where really being a skilled and experienced practitioner comes in so handy, just to have had the real experience with seeing people present in so many different ways. I was very fortunate in my early career that I worked at CAMH and had and Michael Guerin, and had a lot of experience with people with varied backgrounds and multiple morbidity, and also different diagnosis, that just to give you this range of experience that it's not, I generally don't, when I meet someone, think, oh, this is what this is what that is. I like to take some time. I generally don't share what I think right away. And in many cases, it's a combination of things. And to be honest, in most cases, what I'm focusing on is how can I help this person meet the goals that they've come to therapy for. It doesn't necessarily matter the exact root of, is this ADHD, is this trauma, is this both? It's more important that are they improving in therapy? Are they responding well? Are they functioning well? Are they happy with the results and the changes that are happening? Going back to ADHD, the research is consistent on one point, though. A thorough assessment, one that specifically asks about developmental history, not just current symptoms, is the only way to reliably tell those apart. And often, the honest answer isn't either or, it's both feeding each other, which is its own reason to work with someone trained to sit with the complexity rather than reach for the nearest label. So what does the evidence actually say in terms of what's helpful? Well, number one, most people are aware, in Canada, and in Ontario specifically where I work, psychiatrists are generally the people, psychologists as well, but a lot of people are going to a psychiatrist because it's covered by OHIP, it's covered by provincial health insurance. It takes a while to get in to see someone, but they're then diagnosing the person and generally then prescribing some medication. So we're going to talk a bit about medication. So stimulant medication remains the first line, most heavily evidence-backed treatment for core ADHD symptoms in adults. I obviously don't, as a psychotherapist, I don't prescribe medication, but I'm not going to pretend this is not common. The evidence base is large and consistent, but medication has a ceiling. It doesn't teach organizational skills. It doesn't rebuild self-esteem eroded by a lifetime of why can't I just get this together. It doesn't help with things like shame, and it doesn't touch comorbid trauma, anxiety, or depression on its own. Other research is showing evidence for CBT specifically adapted for adult ADHD. So models like Russell Safran's approach has grown substantially in the past few years. Research meta-analysis shows CBT meaningfully improves not just core ADHD symptoms, but the secondary damage, self-esteem, emotional regulation, quality of life, comorbid anxiety and depression. One large meta-analysis in 2025 found something clinically important. CBT plus medication improved executive functioning more than either alone, while CBT alone actually showed a slight edge on day-to-day functioning outcomes over combined treatment. In other words, medication and therapy aren't competing options. They're addressing different parts of the same problem, and the research is increasingly supports using both, matched to what the person actually struggles with most. So what does CBT for ADHD actually target? Well, concretely, it's externalized systems for time and task management, which is often how I approach it, because willpower alone reliably fails. And then if you keep failing, of course, it's going to trigger more shame. The treatment goal is generally to build scaffolding outside the brain, not trying to force better internal discipline, which is often doomed to fail. Cognitive restructuring for shame spiral that builds up over years of missed deadlines, forgotten commitments, parents being disappointed in your progress, employers, etc. The direct work on emotional regulation is very important because dysregulation, not just distractibility, is now recognized as a core, not incidental feature of adult ADHD. And I've seen this for years, and it makes perfect sense when you think about it. When you take the history of a person who years ago, when I worked with someone who had ADHD, they're often told repeatedly how smart they are when they're growing up, how capable they are, because they've shown that in certain times and certain pieces of their life. Yet their marks aren't really reflecting that, and they're not often finishing things or completing things. So then they're getting labeled as a person who, has all this potential but doesn't follow through on it in some way. And of course, that's where the shame comes from, especially as a young person not knowing even what ADHD is. They're like, what's wrong with me? And that's where they're, I'm flawed and broken, something's wrong with me. So a lot of the work I do with clients focuses heavily on the shame and the emotional peace, which can often get overlooked. So somatic and body-based approaches, which is a lot of what I would use, works very well given how much dysregulation comes from ADHD, internal restlessness, difficulty settling, emotional flooding. Body-based regulation practices are a natural complement, particularly for clients where ADHD and trauma is intertwined. This isn't a replacement for structured treatment, it's just a regulation layer underneath it. We can't ignore that part. So coaching and behavioral scaffolding is also something research has shown is very helpful for more executive functioning symptoms, the missed deadlines, the chaotic inbox, 15 open tabs. The ADHD coaching and structural behavioral systems have a real, if less rigorously studied, support. They often are most effective after the emotional and cognitive piece has been addressed in therapy, not as a substitute for it. There are a lot of ADHD coaches out there that people find very helpful. A through line across the current research, though, is that individual treatment outperforms any single intervention alone. There's no one right path. There's a path that fits a specific presentation, your history, and critically where trauma is part of that picture. Obviously, treatment plans and approaching is very individualized to the person. You have to get a good sense of their history and really get a sense of what their life is like, what's going on in their life. I just want to make a quick note about, who gets missed. Well, the people most likely to be traditionally ADHD screened are adults who compensated, most likely to be missed, by traditional ADHD screening are adults who compensated well, or we would call this in trauma like adaptation. They adapted to situations, and they've done it for long enough that nobody flagged it. Often women, often high achievers who built elaborate coping systems that worked well. Females with ADHD are more likely to present with inattentive type ADHD and are more likely to carry comorbid anxiety or depression. At least this is what research has said. So, which historically got treated as a primary issue when the ADHD underneath went unnamed for years, sometimes decades. If you're one of those people diagnosed at 35, 40, 50, whatever age you are, after a lifetime, I'm just disorganized or I'm just anxious, that's not a false or trendy diagnosis. The research on late identified ADHD backs what a lot of people describe, not inflation, but correction. Years ago when I started at ChemH, they had an adult ADHD clinic, and I think it was the only one at the time in Ontario. I can't remember. It was very unusual. We often thought of ADHD 25 years ago as something only children have. We often thought, and I was told at the time, that it would kind of, people would almost grow out of it as they got older. What I think was more happening was that people learned how to cope and hide it better through becoming more developed and more aware psychologically. They learn how to just kind of get by in some way. And there's a lot of people out there that are very successful who are getting by, although inside struggling quite a bit because they can't really talk about what's happening, or they're embarrassed or ashamed to admit it. So in closing, I just like to say that, is it ADHD? Is it trauma? Is it both? I can't answer that for you in a podcast episode. And honestly, anyone who tells you that they can from a symptom checklist alone is skipping the part of the work that actually matters. What I hope you're taking from this, the symptoms are real, whatever the underlying cause turns out to be, and figuring out what that underlying cause and carefully with someone trained to hold both possibilities at once is what actually determines whether treatment works or just spins wheels. As I said earlier, if you have someone trying to work with trying to approach ADHD, but it's actually trauma, they're not going to get very far, and vice versa. It's the same thing, as I said earlier, with anxiety. If I'm trying to work on anxiety, but this anxiety is rooted in unprocessed trauma, the person is just not going to progress well. So a skilled clinician should know that and be able to make adjustments, and also be observing the process to hold multiple possibilities of what's going on with this person before just focusing on one. Because one of the things I learned years ago is that it's not that simple. People are not just like, oh, you're just depressed, or oh, you have anxiety. Like, you may be getting a diagnosis for that, but there's a lot more to it than that. And I think when you sit with people and you understand and listen to their history and their life story, you can frame a picture and get a sense of it. And even if you kind of don't fully get everything there, you can still help them have a better life, improve their life, manage their life better. The name of this podcast is From Surviving to Thriving. So we want to move people out of survival mode into a place where they feel they're thriving and they're fulfilled and they enjoy their life. And that's the primary focus of my practice in this podcast. So thank you for being here. If you feel like you want to get a diagnosis, by all means, I encourage people, talk to your doctor, get a referral, get set up. It'll take a few months, get set up with a psychiatrist, get a diagnosis if it's meaningful to you, and then take that and go forward with that. You'll have to learn, not just the diagnosis won't tell you how to improve your symptoms, but if that's important to you, by all means, take your health seriously, advocate for yourself, and get the help that you need. Don't let anyone else tell you not to. So thanks for listening. I appreciate all the feedback I get on these episodes and the suggestions I get. Until next time, take care.